hearing more about that from Dr. Robinson. About Dr. Robinson is the head of the Department of Obstetrics and Gynecology at the David Ugwuanyi Federal University of Health Science, Ebonyi State, and a consultant obstetrician and gynecologist, as well as reproductive endocrinology, infertility, and in vitro fertilization units at the David Ugwuanyi Federal University Teaching Hospital, Ugwuanyi. He's a researcher, author, teacher, and medical educator with special interest in reproductive medicine and assisted reproductive technology. Dr. Ugwuanyi is a fellow of National Postgraduate Medical College of Nigeria and a fellow of West African College of Surgeons, Faculty of Obstetrics and Gynecology. He obtained his MBBS degree from the University of Benin City. He received his secondary education at St. Teresa College, Nsukka, and his primary education at Community Primary School, Kumabo. Dr. Ugwuanyi is a proud member of Nigerian Medical Association, Medical and Dental Consultant Association of Nigeria, Society of Gynecology and Obstetrics of Nigeria, and Association of Fertility and Reproductive Health. He is the immediate past chairman, NDCAN, David Ugwuanyi Federal University Teaching Hospital, Ugwuanyi, and has previously served as president, Association of Resident Doctors, Federal Medical Center, Ugwuanyi, and secretary, Nigerian Medical Association, Abia State Branch, among other leadership roles. A member of Rotary International, Dr. Ugwuanyi is committed to selfless service to humanity. He's happily married to Mrs. Blessing Chumwaya Ugwuanyi, and their union is blessed with 3 children. Kindly help me welcome Dr. Ugwuanyi as he takes over the stage. So while Dr. Ugwuanyi is presenting, if you have any question, any clarification, kindly drop it in the comment section. So enjoy the session. Thank you, everyone.
Thank you very much. Yet today, can I be heard? Thank you very much for that brief introduction. And also, let me use the opportunity to thank the eClinic and Diagnostic Limited for this initiative, this monthly webinar to educate our people, to educate the world on issues concerning health. So, and also thank you for inviting me to be the resource person for this month's webinar. I'm Dr. Ugwuanyi, a consultant of gynecology. I have not to declare, I just want to say, the next slide here today, I just want to say that I'm a member of the next slide will show you how people that nurtured me. Next slide. Hello. So, no, now, see, I need to control this slide from here. The second page. Go back. So, this is I'll be discussing with us polyendocrine metabolic ovarian syndrome, previously known as polycystic ovary syndrome, PCOS. Can it cause infertility? And what you need to know. That's why I want to declare that the session is not going to be, we're going to break it down so that our non-medics among us, because I'm sure more than 80% of persons listening to us are non-medics. So we want to ensure that non-medics among us will benefit maximally. So we're not going to use so many medical jargon. Well, the idea is that we want to bring out what you need to know about previously known PCOS, now PMOS, polyendocrine metabolic ovarian syndrome. What you need to know. That's our concern. So it's not a medical meeting per se. So we won't bother you with the details, but at least you have some take home. By the end of the day, they will be well informed and know when to seek help. All right, next slide. This is my affiliation. Next slide. So I'm going to be discussing with us using the following outline: introduction, then I'll create some case scenarios from PCOS to PMOS, understanding the fertility, the PMOS and fertility. Keep take notes and I'll conclude. Next slide. So by way of introduction, permit me also to go a bit scientific. The polyendocrine metabolic syndrome, previously known as polycystic ovary syndrome, is actually the most common endocrine disorder affecting females of reproductive age worldwide. So it's very, very common. You see about 10 patients in your gynecology clinic, found out that about 8 of them will have PMOS or PCOS or this maybe. So we're using PCOS and PMOS at the same time for those who may not have understood that the name had changed. And primarily, the pathophysiology, it involves insulin resistance and a high prevalence of visceral deposits, even in absence of obesity. So that somebody is not obese does not mean that the person will not have insulin resistance. There's something called central obesity. It's even more common than overall obesity. So, and what it does is it disrupts the hormonal construct among the hypothalamus, pituitary glands, and ovaries. You know, there's something we call in medicine HPO axis: hypothalamus, pituitary gland, and ovary. You know, a chemical from hypothalamus will instruct pituitary gland to produce a particular chemical, which will now go to the woman's ovary and instruct to produce another chemical. And also, that chemical will also help in the recruiting follicle or the egg, as case may be. So once there is a disruption in any of those pathways, there will be an issue in that one. Next slide, please. Then, but we need to also understand that there are PMOS, polyendocrine metabolic, what's this now? Polyendocrine metabolic syndrome, ovarian syndrome, is also associated with other comorbidities, including infertility. So infertility is just one of the things. And that will tell us why the name had to change. Apart from infertility, patients can have metabolic syndrome, obesity, type 2 diabetes, cardiovascular risk, that is heart disease, can even have depression, or what we call obstructive sleep apnea. Endometrial cancer can also result metabolic dysfunction associated with liver disease, all those stuff. So you find out that it's not just a disease of the ovary, it's not just infertility, but for today's discussion, we'll be emphasizing more on infertility and PMOS. So it's a chronic metabolic disorder requiring a detailed and individual approach to management. It's very key because 5 persons may have this disease condition, but the approach to it will differ depending on the age and what the person wants. So, you know, you don't go to the hospital and tell your gynecologist that my friend had PMOS and this is how my friend was treated. No. The treatment for PMOS is tailored individually based on the need of the patient at the time T. So next slide, please. So there's a high prevalence among first-degree relatives, which means it's actually genetic. So if your mother has PMOS or PCOS, very likely you may also have it. So the portal obesity and other conditions could also cause it. You know, low birth weight at birth. You know, when we are giving birth, you have low birth weight, can be a factor. Also, is more on Mexican Americans than among non-Hispanic white and African women. Go ahead, we won't waste time on this, just to make it a scientific presentation. The prevalence ranges from 5 to 26%. You can see the range is much, from 5 to 26%, depending on diagnostic criteria. But don't bother about that. We are using Rotterdam criteria for diagnosis, which I will tell us as we move on. Now, go on, don't bother with this. Now, I want to paint a case scenario so that we understand why we are doing this webinar today. So how many of us have heard someone say, I have cysts on my ovaries, or I have PCOS? It's very common. I'm sure if you up to front of here, I'm sure more than 80 must have heard that. I have cysts, I have PCOS. Another question I want to ask is this. What if I told you that many women diagnosed with PCOS do not actually have ovarian cysts? You can see how misleading the previous name would be. Because you can actually do a scan in a woman and the ovaries are not cystic, but she has PCOS. That will tell you that PCOS or non-core PMOS is not just about the ovary. It's about the endocrine metabolic and other metabolic issues in the woman. And what if I also told you that the ovaries may not even be the problem? I have seen several women in our clinic that has that we made that of PCOS then, and they didn't have polycystic ovary. And that is why the criteria for making diagnosis, you have to two out of the three. One is that the oligo and ovulation, maybe a woman who is not ovulating, who has irregular menses, which are going to define, or a woman who has hirsutism, has male pattern of hair distribution, or has a polycystic ovary. So if you have two out of the three, that person has gotten PCOS or PMOS. So if a woman, the ovary is normal, but she has issues with ovulation, she has issue with the androgen, then that woman has PCOS or PMOS, I guess maybe. So today I want us to rethink one of the most common hormonal disorder affecting women worldwide. Instead of viewing it simply as PCOS, we will explore why many experts now see it as complex condition involving multiple hormones, metabolism, reproduction, and even mental health. Yes, mental health. We comported mental health to this treatment of PCOS, as we're going to see as we progress. In other words, this is not just a ovarian condition; it is the whole body condition. It's even if you not pick anything to start it. Understand the whole body condition, not just ovary. So let me introduce you to one of our clients, Miss Joy. Miss Joy. Miss Joy is 27-year-old. She noticed that her period had become irregular. Sometimes she skipped months without seeing her period. She gets weight despite doing exercise. She gyms every morning. She kept on gaining weight. She developed acne, what they call pimple, that refuses to go away despite using several creams to get out. She started noticing unwanted facial hair. She just discovered that she's growing hair here and there, and she feels tired most of the time, and she now decided to see her doctor. So after an ultrasound, she was told she has PCOS. She leaves the clinic believing that her problem is with her ovary. But what nobody explained to her in that clinic is her ovary are only one part of a much bigger problem. That the real story involves insulin metabolism, inflammation, genetics, and communication between multiple organs. Now, the problem with the name PCOS. So I just give you a scenario of Miss Joy. How she went home telling people that they say she has problem with the ovary. Without even knowing that ovary is just one part of it. Which means if that doctor did not do scan and did not take proper history, the doctor, or if the doctor had done scan and the ovaries were not polycystic, the doctor would have said no problem, go home. So the name has got a lot of issue, and that's why in May 2nd this year, 2026, the name was officially changed. So the name polycystic ovary syndrome was introduced decades ago. At that time, doctors focused mainly on what they could see in the ovaries. However, modern science has revealed several problems with the name. First, many women with PCOS do not have polycystic ovary, do not have ovarian cysts, like I said before. All right, let's start it today. So, next slide. Are you with me? What is this? Go back to the next slide. I don't like it. So some women have polycystic looking ovary. Go to the next slide here today. I don't want to use another device for this. Stop there. Second, some women have polycystic looking ovaries, but do not have the symptom. So you may do a scan. It's very important that our ladies understand this. We may do a scan and we see, in fact, even yesterday, the last time I did yesterday, you might have polycystic ovary, but they do not have the symptom. So it's all that there's multiple cysts that are not up to 10 millimeter on the ovaries. So, but she don't have the symptom. So PCO is not symptom PCOS. And the condition affects just far more than reproduction. By the time I give us the second scenario of Miss Anita, you understand what I'm talking about. It's not about only reproduction. It's going beyond reproduction, even though we're going to emphasize more on reproduction today. So the name highlight the ovaries, why hiding the endocrine and metabolic disorder. So the previous name PCOS is paid more emphasis on the ovary. Why hiding the endocrine and metabolic disturbances that often drive the disease? Next. So what does polyendocrine mean? Poly simply means many. Endocrine means hormones. Therefore, polyendocrine means that multiple hormones producing organs are involved. Just think of an orchestra. For beautiful music, every instrument must be synchronized. You know, for those of you who are choristers, for you to produce music, it means that every instrument must be synchronized. Not when you are drumming, another person is playing out of the piano. Everything must be synchronized. So several actions of orchestra begin playing out of. But in PCOS, what we see is that the orchestra will play out of rhythm or out of tune. That's just PCOS. But we are all involved. When I say we here, look at the brain, the ovaries, the pancreas, the adrenal glands, the fat tissues are all involved in PCOS, not just ovary. So ovary is just one out of 5 organs that are involved. Go ahead. So the hidden driver, please, I actually noted this because 70% of cases of polyendocrine metabolic ovarian disorder or syndrome is driven by insulin resistance. So it's not even what we think is over. It's insulin resistant. And what happened? Insulin, think of insulin as a key that opens door or opens a lock. So if the lock gets rusty, then this means the body begin to make more insulins without any consequences. Because this insulin won't be able to enter the door. It will be able to open the door. And the body, because the insulin will open the door, the body will sense that this insulin is small, this insulin is not adequate, and keep on producing much more insulin. And what do you have? You see person with PMOS having increased androgen production, going here like man, having deepness of the voice, you know, then increased fat storage, growing especially central obesity, hunger, increased hunger. Some start losing weight, some have increased risk of diabetes just because of insulin resistance. In all this, do you see anywhere I mentioned over? Now, there's this thinking that once you're overweight, you must develop PCOS. The answer is not so. We've seen so many women that are obese, and they have 5, 10 children, and they don't have PMOS. So beyond the production, PMOS dispose us to pre-diabetes. You know, pre-diabetes is just what call it now? It's just a thin line between pre-diabetes and diabetes. And this is what you see, especially who have tumors. Or over diabetes, type 2 diabetes, high blood pressure, abnormal cholesterol level, and fatty liver. These are things that tumors can cause, not just reproduction. Yeah, go on. Then mental health. I told you part of the introduction that mental health has been incorporated fully because some of who have PMOS, who have a metabolic disorder and endocrine disorder, will be very anxious and depressed, low self-esteem, and body image concerns. And that is why in modern contemporary gynecology practice, we have incorporated mental health team to the management of PMOS because of the weight and low self-esteem, and the person believes that they're also good in me again, and you need to talk to the person. Why you tell the person to try to lose weight, you have to talk to the person on eating habits. You know, when somebody is depressed, they tend to eat more, eat junks and all those stuff. So the mental health concern is very important. Wow. So let me also put, I say I will introduce us again to Miss Anita. Anita is a 35-year-old, and she was diagnosed of PCOS at the age of 19. At that time, treatment focused on regulating her menstrual cycle. So because she was not married then, and the concern is just to let her stay her period every month. So she was given just a contraceptive combined only contraceptive PS to regulate her cycle. Nobody changed her blood sugar. Nobody discussed cardiovascular risk with her. We just focus because it focused on the meds. Go on. That's what happened to her later. Go ahead. Next slide. So nobody explains insulin resistance, but 15 years later, she developed type 2 diabetes. Now, the question is, could this have been prevented? Perhaps not entirely, but early recognition of this metabolic aspect could have reduced the risk. Probably when she was 19, if somebody had just taken time to do her fasting blood sugar after making that diet of PCOS, fasting blood sugar, we have discovered that either she had pre-diabetes at that point, or she has got over diabetes mellitus, and treatment was started on time. And this is why our understanding of the condition must evolve. We must not think that it's all about reproduction. So, as of May 2026, I just lifted from last publication of 2nd May 2026. Following a global consensus process published in the Lancet, involving over 14,000 stakeholders and 56 international organizations, the condition, previously known as PCOS, has been formally renamed PMOS, Polyendocrine Metabolic Ovarian Syndrome. Why? Because of what I discussed just a few minutes ago. Move on. Next slide. Now, why the change in name? Why the change in name? The consensus believed that changing this name will improve scientific accuracy, which is true. Reflects multisystemic pathophysiology to show that it's not just ovary, that it involves the brain, it involves the adrenal, it involves the pancreas, it involves the fat tissues, and to reduce stigma. Very important. It brings me to reduce stigma. You see, if you go to social media, you Instagram, you say PCS group, PCS this, PCS this, just encourage themselves as if to say they've got something so serious. As you can see, that it's not too much a serious thing in terms of production. If you don't have any metabolic or endocrine disorder, just that your menses is not coming regular, it's not a big thing for us in infertility. And be culturally acceptable internationally and be feasible to implement globally. So these are the things the consensus believe that when the name is changed, that we're able to have all this stuff. Next slide. Next. It's there. Are you with me there? Okay, go ahead. Go to the next slide. Go to the next slide. So, according to the authors, polyendocrine acknowledges involvement of multiple endocrine, like I said. You're overshooting though. Give out the next slide, please. So, although I've mentioned this, ovary preserve the reproductive. Okay, go ahead. So, what is needed now? We are approaching while we're approaching the reason for this webinar. So, what is needed for conception? What are the things needed for pregnancy to occur? You will need healthy egg development. We need with table ovulation. We need healthy sperm function. We need open and functional fallopian tubes. We need a receptive uterine environment and a balanced hormonal signal. You can see that with the table ovulation, it's just one of the things. Ovulation is just one of the things you need for pregnancy to occur. So it means that PMOS can only interfere with ovulation function, hormonal regulation, and follicle and egg development. Now, like I said before, the signal comes from the brain. The brain will send the hormonal signal to the ovarian follicle, which will now lead to ovulation and potential conception. So once there is any distortion from the brain to the ovum, then the conception may be difficult to achieve. And that is where PMOS and infertility comes, how it can cause infertility. Go ahead. So in PMOS, Polyendocrine Metabolic Ovarian syndrome, there's hormonal imbalance develops. How I say it, there is oligo-ovulation or anovulation. So when this hormonal balance will cause an increase in androgen level. Androgen is like a chemical or hormone that's more in men. By the time a woman starts having such hormone more, then it means that what called hyperandrogenism, and that's part of the criteria for making diagnosis of PMOS. So when this androgen rises, it means that the follicle is contained in the ovary may not mature properly, and ovulation may not be there, or may just be irregular ovulation, and fertility may be reduced. This just how PMOS affect fertility. Go on. So it's from hormonal imbalance. That's like now insulin resistance, an important piece of puzzle. Why it matters. So when you have elevated insulin level, like I explained before, it will stimulate this excess androgen production. So this androgen, which is ordinarily supposed to be a male hormone, will become more in a female. And once it becomes more in a female, it will impair, it will restore the maturation of follicle or the egg, as case may be. And we said there must be a healthy egg for a woman to get pregnant. So this insulin resistance, which is very common, control about 70% in cases of PCL in PMOS, will ensure that there's no good quality egg. And once there's no good quality egg, the woman will not get pregnant. It's as simple as that. So there's this take firm notice. I intentionally put on red that PMOS is not solely a reproductive condition, it's also linked to metabolic health, which will still come around and affect the reproduction. Next slide. Now, there's something I bought this slide for clarity, because one of the criteria for making diagnosis of PCOS is anovulation or oligovulation. That's irregular menses. But I want to put something out here that what most of us call irregular menses are not actually irregular menses, they're regular. That is why if you think you have problem with your menstruation, you should see a gynecologist who will now educate you properly. If a lady just started seeing her periods, and within less than 1 year still have, or she starts seeing her periods, the period has not been coming. Maybe 3 months skip, 6 months, she has not seen it. It's normal. It's not, she doesn't have irregular menses. the first year post-menarche, the person has not got regular menses. However, if between the first and less than 3 years that she starts seeing her period, if the least of her menstrual length is less than 21 days or higher than 45 days, we can now say yes, she has got irregular menses. So if the woman starts seeing her period at the age of 16 and the woman presents you at the age of 18, the lady person at the age of 18, that's like my menses is not regular. I've not seen my menses for the past 35 days, for the past 40 days. Just cancel her that is part of it, that is normal for that age group. Because of what we call immature HPO axis, autonomous pituitary and other things. I say I'm trying as much as I can not to use so much medical jargon. To just tell the person that and assure the person that there's no problem. And if there's anybody in this audience that has this issue or has a child who just 16 or 18 and not menses appear not to be coming every month, don't bother. Then within 3 years, so maybe after 3 years to before menopause, what will tell me regular menses is the cycle length less than 21 days or cycle length more than 35 days. So if the period between when you saw your last period and the next one is more than 35 days, and you are an adult, we can simply say you have irregular menses. If it's less than 21 days, you can say you have irregular menses. Or in 1 year, in one whole year, you have less than 8 cycles in 12 months. You say it's irregular. Please. Thank you. Then, again, thank you. No, go ahead. Go back to the next slide. Go back to the last slide. Last slide. You must be with me. So then, any cycle 1 year after the first period that is more than 90 days, the woman starts saying her period at age of 15, and by age of 17, she's still her period for up to more than 90 days. Is irregular menses. All right, go ahead. Go to the next slide. So how do they present? Most of the women, they present with skip period, like I just explained. That's why I have to bring out that slide for this one. Longer menstrual cycles, I just explained it. One predictable bleeding pattern. They will tell you that I don't even know how my period is. I can't explain. And I always advise the ladies, please, your phone is not just for TikTok. Once your period starts, go and put it somewhere in your phone so that you can always relate if there's abnormality or if you meet a health personnel who ask you when you see your last period. You're able to tell the story how your period had been from in the last 6 months, and you can do that with your phone, and it will help us. It will help us to know that this period is regular, not irregular. But it is basis for any intervention I'm going to do for you. Then, impact on fertility, like I said, less frequent ovulation and fewer opportunities for conception. See, I've been using this word, less frequent ovulation, fewer opportunities for conception, to tell you that if the woman's problem is just ovulation, if the other aspect of fertility, if a conception is taken care of, the sperm is fine, the tubes are fine, the uterus inside of the womb is fine, but just the problem is ovulation. In more than 80% of cases, we'll smile because we know that the problem is solvable. All right, go ahead. So we have to separate the fact from fiction. PMOS and infertility. Let's take note. Women with PMOS or PCS cannot become pregnant. That's a myth. Not true. I'm saying it here because it's very common in our environment. But I have like 2 cases I'm handling now that well, some of them may even be listening to me here, that the husband or the fiancés about quit because they made us of PCS. They don't quit. PCS, if PCS the only problem she has not got much problem in terms of fertility because we cannot handle it. In more than 80% of cases, when we give blood, the woman will ovulate and will get pregnant. So please, yeah, it's a myth. A woman with PCS can get pregnant. In fact, the fact is that most women with PMOS and PCS are able to conceive either naturally or with medical support when needed. Now, why am I saying naturally? Sometimes because of the messes, you may just study a woman's menstrual pattern and advise the woman and the husband going to have an affair, and it will work. You know, and this is very common among the elites. You know, those who are not so busy, you don't need to even calculate when to meet your husband. If you can meet your husband at 3 days in a week, very likely you're going to get pregnant. So, but for the elite who are very busy, some people say we meet only during a fertile period. And you ask person, when is your fertile period? Person doesn't know because person doesn't keep records. It's not everybody let me just say it. It's not every woman that ovulates on day 14. Those that ovulate on day 14 are those that their menstrual cycle is 28 days. So if your menstrual cycle length is on 26 days, it means that you are going to ovulate on day 12. If it's 30 days, it means you are going to ovulate on day 16. If it's 32 days, you're going to ovulate on day 18. But they just assume that today is my day 4th, I'm ovulate today, let me meet my husband. We'll have cases where all you're there to do is to listen to the woman and study the menstrual pattern and say, madam, have a fair at this or some time. And they consider naturally. That's why I put natural there. Or maybe someone who's not actually ovulating, they can give some medication and this will ovulate and get pregnant. So important distinction here is that PCOS is often associated with reduced fertility rather than permanent fertility, rather than permanent infertility. So it's more of reduced fertility than permanent. Thank you. So next slide. So we have other, apart from the ovulation issue, we have other factors that can affect fertility, like body weight. You know, excess body weight. And that's why many times when the patient comes, we just ask you if you can lose 10% of your weight. They're very likely that you might conceive without any medication. Then age, whether I would like it or not, or from age of 40, a woman, even any woman will need help to get, most women will need help to get, because the like I said, it declines. You know, I always tell women that this one is natural. You cannot, if you ovulate every month, it's all about 400 fertilizable egg in a woman, fertilizable. So, and if an egg leaves your body every month, just imagine you start seeing your period at age of 16, and you'll be ovulating at least one egg every month. Could be 12 in a year. Now, by the time you are 40, that should be 24 years later. But like 24 by 12, know how much of the eggs that have ovulated. They know how much of it is left. How many of them are left? So it's just natural. Not anybody can know about that. Then male factor infertility, I mentioned it. In fact, the male factor infertility, let me also say it here, it's becoming more common than male factor. Before we say 30% to male, 30 to female, 30 to both of them, 10 to unknown. But now it's going towards 50, 20, 30, 10. I'm telling you honestly. So the male factor infertility is becoming increasingly high, maybe because of the lifestyle changes and what have you. Then other lifestyle factors like stress, poor sleep, inactivity can contribute to hormonal disturbances. So stress, poor sleep. Of course, we know the benefit of sleeping well. Even at our primary school, we are taught that the best form of rest is sleep. No matter how busy you are, try and find time to sleep. Thank you. Next slide. So, does PMOS influence air quality? I've actually talked about this. The answer is yes. It affects the maturation, it affects the molecular health, executive stress, and environment. But the encouraging news is that healthy lifestyle changes may help improve reproductive health and air quality. I just mentioned this. Healthy lifestyle changes. Try to control your weight. Try to know what you eat. Eat intentionally. I will say eat intentionally. You don't eat anything you see on the street. Try at least this center of weight we are talking about to be able to escape it. So when you be able to shed some weight, because of fat, excessive fat tissues increases this androgen you're talking about, which is also not good for reproductive health. So by the time you burn down those fat tissues, we'll have less androgen. Then now we'll have more estrogen and progesterone in the system that will make you a woman. Then you find out that those excessive hair growths will just naturally disappear when the androgens have been reduced. Next slide. Next. Today. Yeah. Next slide. So we have available fertility treatment. First, before we give drug, what the so-called foundation of care. I mentioned it: nutrition, eating habits, eating healthy. That nutrition. So from primary school, we are also told about balanced diet. So try and eat whatever you're eating, eat personally. Make sure whatever you're eating is balanced. That's what eating healthy means. And also try as much as you can not to eat late at night. Like I advise my clients many a time. I say, if you can make it at the point of duty that you not eat after 7 p.m., it's doable. Sometimes the kind of work you do. Once you come back to your house at 7 p.m., just go for fruits only. It's a part of eating healthy. And initially you may not feel so good about it, but with time you enjoy it and it become part of you, and you will see it reflecting on an improved reproductive processes. The regular physical activities, at least 3 to 4 times in a week, you engage in 45 minutes of these physical activities. You mustn't go to gym. You can just be walking, but you have to walk intentionally. Now, if you decide to walk maybe like 1 kilometer or maybe 500 meters, it means that if you are doing that walk out 500 meters, what it means that you should not be somebody on the road. If not, what they are doing is suffering. So you must be intentional, because everything starts from the brain. Okay, I'm going to run from here to there. Intentional. And that's what physical activity is all about. So you mustn't go and carry weights with gym. No, that's not just. Then weight optimization, then good sleep hygiene. I mentioned before. That's the best form of rest. Sleep. You must sleep at least, at night. What's come to worse, should sleep at least between 6, at least minimum of 6 hours at night will be fine. Now, we'll not have medical therapy. Like I said, this is not a discussion for audience, so I won't bother you with. By the time you get to the hospital, we also place some drugs. But I need to mention some drugs here, because we use it also to induce ovulation. We use clomiphene citrate. Clomiphene is what called clomid. I'm sure if you see 10 women who are having issue with fertility, about 9 must have taken clomid, either by themselves or given to them by friends or chemists or all those. And that's why we're having resistance to clomid. That's why I'm emphasizing it here, bring it out. So we have abused clomid in this part of the world that it appears not to be working again. And that's why our first line now is letrozole. So so what am I trying to say? Please, fertility drugs are not paracetamol, are not just paracetamol. Fertility drugs should be prescribed by a gynecologist, an expert who have listened to your story, who have examined you, who have investigated you, and know what you need. Not that you just somebody go and buy clothing from chemists and swallow. Some people think that I've been swallowing Clomid since my first day of mesis, and that person is seeing on the 21. And plus, I've been taking Clomid from first day of mesis of 21. I don't know the protocol, but you can ask, find out that it's given by one nurse somewhere, or one midwife somewhere, or one friend somewhere. So, and it has caused us a lot of issues now, because if you use Clomid now to induce ovulation, many times you don't get results because of resistance. So we have started to do it also. I made for me, like I say, why is it made for me? Because of the diabetes type 2 that are associated with PCOS or PMOS, because of insulin resistance. Then it's only when, you see, many times the lifestyle modification and medical therapy will solve the problem more than 80% of cases, or 90%. You can see why I said that PMOS will really result on temporal infertility. Temporal. It's not a permanent infertility. So it's only in very rare cases, in 10 to 15% of cases, that we may need to further go into intrauterine insemination or IVF. The patient would problem just PCOS. Very rare case that we move into IUI or IVF. Go on. Now, fertility outcomes are often positive. I have to highlight that. They're often positive, because we need to give hope to patients with PMOS in terms of fertility. They are hopeful. Many women achieve regular ovulation following treatments, become pregnant, deliver healthy babies. So the message of reassurance is that PMOS may create challenges, but successful pregnancy remains achievable for many women. That's the take home here, and it's the message of reassurance. Go on. Next slide. Okay, thank you. So now, the pregnancy consideration in women with PMOS, even when they get pregnant, they are at risk of some medical condition. They are at risk of some medical condition, and that is why we have to bring this up, so that by the time you had PCOS and finally got pregnant, it's not a time to say, okay, this gynecologic clinic is too expensive. Let me go and register. Let me go to health center or to TBS, national medical attendant, to take care of my baby. Please, I want to emphasize this. Because of this pregnancy did not come natural, and because they have polycystic ovary syndrome or PMOS, this pregnancy must be monitored in a gynecological obstetrician-led facility. It's very important because of this increased likelihood of some medical conditions like gestational diabetes, GDM, or GDM, diabetes that is associated with pregnancy. But it can result in baby dying inside the womb if not well controlled. So, elevated blood pressure could even snowball to preeclampsia. Preeclampsia is a special type of high blood pressure that's still pregnancy in placenta. And unless you deliver the baby and placenta, you will not solve the problem. Pregnancy lost. So, it's not just enough that you have seen a gynecologist, you have gotten pregnant, following ovulation induction, or whatever. When you get pregnant, that pregnancy must be monitored. We've had cases where some women felt that this place is too expensive. Let me just get pregnant and I'll go to a health center. And they'll go there and they lose the baby. So please, because of this increased rates, we advocate that even if you don't want to register in the place where you attended your fertility clinic, go to a place, go to an obstetrician-led facility for your antenatal. Very important. So, when conception counseling and early prenatal care can help reduce this rate, I just mentioned it. I have to highlight this on way. Because if you be able to be under care of a specialist, some of these risks will be reduced drastically. Next slide. All right, so supporting future reproductive health, we have just to emphasize, maintain the healthy body weight, improve insulin sensitivity, monitor menstrual pattern, and build metabolic risk factor, and seek fertility advice sooner rather than later. Very important. I just talked about Miss Anita, that was diagnosed with PCOS at the age of 19. And doctor just reassured But at 35 years, she developed diabetes mellitus type 2 because she was not properly cancelled. Next slide. Next slide. So this is the important take home for us here. PMOS affects multiple hormonal and metabolic pathways, not just ovary. It remains a leading cause of ovulatory infertility worldwide. Mark my word, ovulatory infertility, not just infertility. Like I said before, there are other things, there are 5 things that can cause infertility. The tools may not be good, the sperm may not be good, the womb may not be good. So ovary is just one of them. But PMOS affects is the leading cause of ovulatory infertility worldwide. So a diagnosis of PMOS does not mean pregnancy is impossible. Please, even if you don't pick anything from this webinar, you pick this number 3, that diagnosis of PMOS does not mean that pregnancy is impossible. Early intervention can improve reproductive outcomes, and most women can achieve their fertility goals with appropriate care. Even if you want to have 4 children, 5 children. In fact, we have clients that, all their children, in fact, there's one now we're inducing for a 3rd time. The first one was full ovulation induction, second one full ovulation. This 3rd one, she will be induced. And by God's grace, we're going to achieve results. Go ahead. Well, next slide, if there's any. Okay, by way of conclusion, polyendocrine metabolic ovarian syndrome can influence body function, but it does not define a woman's fertility future. It does not. With timely diagnosis, appropriate metabolic management, healthy lifestyle practices, and evidence-based fertility treatment. Please mark the word evidence-based. There are a lot of people out there that claim to be fertility experts. There are a lot of things that they mix out there. A lot of herbal preparation out there. Those things are not evidence-based. So that's why I have to. Many women successfully conceive and have baby pregnancies. This slide should be. Hello. All right, it's not the final slide. So thank you very much for your audience. So it's over to you.
All right. Thank you very much for this wonderful presentation. It's really insightful, really insightful and educative. Thank you very much, Dr. Robinson. Now we'll be taking questions. So if you have any question for Dr. Robinson, kindly drop in the comment section. Any question, any clarification, kindly drop in the comment section. Okay. Mr. Albert is raising his hand, so kindly unmute so you can speak, Mr. Albert. All right, so the administrator, kindly
Good
unmute.
morning.
Yes.
Good morning, everyone.
Good morning.
Good morning. Dr. Robinson, good morning, sir.
Good morning, my manager.
Yes, sir. Good morning. Please, I am seeking for an advice in this forum. A young girl started menstruating at the age of 9. Is there any defects or any problem there?
Okay.
Hello, sir.
Yeah. Thank you. Let's just answer the questions first. Yes, the menstruation at the age of 9 that we classify it as a precocious puberty. You know, the youngest mother in the world is at was at age of 7 or so. No correct. The youngest mother. So that's precocious puberty, and there's a treatment for that. So if a young girl is menstruating at age of 9, that patient should be the girl should be brought to gynecologist. Let's investigate to be sure that there are no other comorbidities. Then if we find out that the problem is just that she's menstruating, because we need to also scan her and look at other issues surrounding her, because many times it doesn't come in isolation. So if we find out that the problem is just that menstruation, there's a treatment for that. So please, menstruation at the age of 9 needs evaluation. Thank you.
Thank you very much.
All right. We previously had Mr. Zakaria raising hands. Mr. Zakaria, are you still there?
Yes, I am. It's Zakia. Thank you. Yeah, thank you very much. Once again, thank you for this very enlightening session, and thank you, Doctor, for breaking down so many things that we thought we knew, but we just got to learn them seamlessly from you. So my question is a bit on ovulation. It's more on ovulation rather. About if you can just I know there's no much time to explain it, but that issue of how many days of cycle do one should look out for, because for us that do correspondence marriages, like we don't live together, so we kind of try to use those windows as much as we can. So if you can just explain how many days of cycle starts from the 12th day, 12 days, or how many days of cycle should one start counting for mine. I do more of 27, 26, or 7 days of my cycle is 26 or 27 days, so that's an example. So it's just to get to understand it more. And that's my question. Thank you.
Okay, thank you very much, Sazan. The LCM of it is this. Whatever, if you have 28-day cycle, just minus 14 from your day of cycle. Whatever you get is your day of ovulation. So if you have 28 days minus 14 will give you 14 days. So we are going to ovulate on the 14th. If you have 30 days, 30 minus 14 will give you 16. We will ovulate on day 16. If you have 32 days, 32 minus 14 will give you 18. You wait on the 18. However, let me also say it here. Then the way we calculate days in menstrual cycle is the first day your period came out. Even if it is sperm, that becomes day 1. You understand me? The first day of your menstrual cycle becomes day 1. So second day 2. So for you, that if you have 26-day cycle, it means 26 minus 14 will give you 12. Which means if your period started on 1st of May, it means you are going to ovulate on 12th of May. Now, for correspondence marriage, as you put it, what we advocate is this. There's what you call predict. Predict is what's commonly known as ovulation test kit. I will also emphasize it here that you see climbing vaginal discharge on your day 12 does not mean that you ovulated. Let me say it here, please, because I want to say I saw my ovulation. You see, what that means that your chemical, we call it luteinizing hormone, which helps in final maturation of the ovulation, is high at that point. And it should be high. If that chemical is high, when you do your predict, it will be positive. You should see 2 lines. But that does not mean that you ovulated. This is why if you see a patient who are thinking has an ovulation issue, you will say, okay, let's do a mid-luteal phase progesterone test. which is expected to be high. Because if the woman ovulated, it's assumed that if the woman has 28-day cycle and ovulated on the 14th, when you check her progesterone on the 21, you expect to be at least up to 16. So it should be high. So it's only that the surest test of ovulation is pregnancy, followed by when you do a progesterone. Even when you do your transvaginal scan on day 12 and you see a abdominal follicle up to 18 millimeter, that does not mean that you've ovulated. Please. So it means that you can, because there's something called LUF, luteinized unruptured follicle. So when we still have abdominal follicle, but we still go along, I will not ovulate. And by the time that abdominal follicle will now regress to grace, we conceive with our next message. And the person will say, I had miscarriage, that I saw this egg on the 12th. That's why we advise our doctors and also sonographers, please, when you do your transvaginal scan and abdominal follicle, don't tell the woman that you must ovulate or you are going to ovulate tomorrow. So many times we also give drug at that point to help in final maturation and ovulation. So for the correspondent marriage, as is rightly pointed out, so when at that, if you have this kind of if you have on the 12th, you have do your predict test or you do your transvaginal scan and the dominant follicle. So it's expected, and that from that point, it's expected that in the next 34 to 36 hours, you are going to ovulate. So which means if you say your day 12 is today, to next 36 hours, the first 36 hours should be next tomorrow around the same time, just so that you are going to ovulate. So within that time, you expect to meet your husband. Now, that is to meet your husband after ovulation. Then you can still do 24 hours later. From that time, your credits show 2 lines. You can still meet your husband 24 hours later, they meet again 36 hours later. To ensure, because the idea is that the sperm may not be able to, you cannot the egg, you cannot vouch that the egg will stay there more than 24 hours or the sperm will stay more than 24 hours. That's why even if you are doing an IUI now, we are thinking of doing double insemination. You give your trigger 24 hours, you inseminate, 36 hours, you inseminate again, just to be double sure. But nobody is very sure the lifestyle of the life span of an egg that has been ovulated. So, but then after 24 hours, nobody is sure again. So, 24 hours before ovulation, within the ovulation, 24 hours after ovulation. These are the windows that some of us think is the most fertile window that works for us. Thank you. Get to the over to you. You are muted.
All right. Thank you very much for the elaborate explanation. Thank you very much. So we have question in the chat box from Dr. Erudite. Autism remain one of the key clinical features of PMOS, yet baseline hair distribution and density vary considerably across ethnic groups. In population where increased body hair may be a normal phenotypic characteristic, how do you differentiate physiological hair growth from clinically significant autism? And do you believe current scoring systems, such as the Ferryman-Galway score, adequately account for ethnic variability?
Okay, thank you very much. Thank you for that question. Now, you see, if you listen, when I was making my presentation, I said that there is some women that are very, very hairy. They have 5 children. In fact, you can actually, there are some creams when you apply, you start going here, just like you said. So, but the biochemical, we have a biochemical diagnosis. When you do your luteinizing hormone, progesterone, testosterone assay, in fact, if it is high, if it is biochemical demonstrate hyperandrogenism, that is the one that may be a problem in PCOS. Not that And like I said, that does also mean that it will affect it will definitely affect ovulation. No. And that is why one of the individualized management of PMOS is some people just come and say, I don't like these hairs that's all over me. You know, I don't like the hairs that are all over me. When you answer your androgen, the androgen hormone, and it's hard, then you can begin to just concentrate, apart from clipping or shaving and all those stuff. You can also give drug that will stop the hair from coming out. That's what the patient wants. Patient is not interested in reproduction. So, and for the scale you mentioned, well, is theory, and some of us also understand that some of these things we are not done here, but we are also obliged to follow it. So, I do not want to pay too much attention on that because this concentration here was infertility and PMOS. So that's why I didn't pay attention on those scales, because, and also the audience I was talking to. But as for whether I believe in it, that's why I don't have any choice to believe. But you also understand, because if you've not done your own research, you cannot counter somebody's research. If you have done your own research and not publish it, the one that is published, you must follow it. So I right from medical school, that still has been an issue, but I don't have choice than to believe in it. So, but as per hypothesis, if it's not metabolic, if it's not metabolic, it don't have metabolic issue, there's no problem with that. We've had women that are hairy and they are giving birth. If you check the androgens, the androgens are normal level. So the is not pathologic, yes, pathologic hypothesis. That one is physiological. Physiological hypothesis, there's no issue about that. Thank you. Yetunde. Tell that. Thank you very much.
All right. Okay. The next question we have in the chat box is: I am 46 years old and I started my period when I was 12. For like 2 months, I have not seen my period and I discovered that I'm gaining weight. Please, I hope this is not menopause. In addition, I'm willing to have more children, although I have blocked my fallopian tube. What's the way forward, please?
She has what in fallopian tube, please. Read it again. She has what in fallopian tube.
Okay, in addition, the last paragraph. In addition, I'm willing to have more children, although I have blocked fallopian tube. So what's the way forward, please?
Okay. She has blocked fallopian tubes.
Yes, although I have
let me start from there. Let me start from there. If you have blocked fallopian tubes, the two fallopian are blocked. The way forward is IVF. And if you not see your pill for 2 months, you need to also see a gynecologist. Let's be sure is we will not call it menopause yet. We'll call it menopause if you not see it for 1 year. So for us, for now, it is just we can even call this oligomenorrhea or standard menopause. So you don't conclude yet. It's when you not see it for 1 year. We cannot likely say you have got menopause. Then if you stay, even if you are menopausal and you still want to have and you have no fallopian tube and still want to have more children, it can be it's doable. Just that you're going to be a donor egg IVF. For now, we still allow IVF to the level of to the age of 55. I know some people also do IVF after 55 years, but that one is with so much risk. So you can still have an IVF with donor egg, and you have more children if you want. Thank you.
Thank you very much for that, Doctor. Our next question is: what is the best treatment for amenorrhea, and are there supplement that can help with PMOS?
Okay, amenorrhea. When you say best treatment, it depends on what considered amenorrhea. So we have approaches of managing amenorrhea. So amenorrhea can be primary or secondary. Primary is that this lady has not seen her period for the first time in life. Secondary is that the person's just already stopped seeing her period when she's not up to the age of menopause, and she has had a period for more than 6 months and above. So when such person comes, this will be evaluated, and they will know what is causing them anywhere, and they will tackle it. Many times in our environment, when you come, first of all, we'll do a pregnancy test for you to be sure you're not pregnant. When you're not pregnant, we'll not consider doing workup, we'll just do a challenge test. We'll give you a drug, we'll take and see whether you can bleed after we're doing that for more. Then if that is not acceptable, if that doesn't work, we also will upgrade to add another drug for you and to establish. Because if you don't see a period, you want to establish whether it's at the outflow, from your womb to the outside, is it that there's a blockage there, or is that you're not ovulating, or is that it's coming from the higher center. These are three things we examine, and whatever, by the time we do those tests, we know where it's coming from, then we'll tackle it appropriately. But if we finally find out that this is coming from the higher center, I don't think anybody can do about it. There's also medication we can give you and advise you appropriately, depending on what you want. Like I always tell women, I don't think not sleep period is the issue. The issue is that they want to get pregnant. If you have completed your family size and period is not coming, it's not an economic saving policy for you, medium for you. You expect from buying sanitary pad every month. So, but the issue here is that you want to get pregnant. Like when they come, they say, "I'm not seeing a period." They say, "I'm." A signal that there's something happening with the ovulation. A woman who ovulates, a woman who sees her period regularly, is unlikely not to be ovulating. That's the ABC of it. Because let me just mention here the physiology of what happened to the physiology, the how period comes about is that every month, the way God designed woman body, every month it's expected that a woman will get pregnant, a kind of. When the woman ovulates, if egg leaves the ovary, where that egg is coming from will form a cyst we call couple lutein cyst. That couple lutein cyst, what does it do? It will start producing chemical we call progesterone that will act on the inside of the womb to sustain that baby you put that will be implanted there for the first 14 days. So it's assumed that after the first 14 days, after the first 14 days, then baby and the mother and the placenta will now continue to produce that chemical to sustain the baby, till delivery. So if a woman ovulates, that's the normal process. Now, if the woman did not get pregnant and that cyst, couple lutein cyst, stop producing that chemical by the 14th, what happened? And there was no pregnancy. The womb will start crying that I didn't get pregnant. What called weeping womb. That's menstruation. So, but if there was no ovulation, there won't be any that chemical at all. So there won't be any withdrawal and there won't be any weeping. And that's the woman will not see her period. Now, every month, the elemental line will keep on increasing. So after about 3 months, then it will start sloughing, coming out in clots like flesh. And that woman will tell you that I was pregnant for 3 months and the devil came and I had miscarriage. And when you ask her, "Madam, do you do pregnancy test?" You say no. So you know that what she has got, what we call metapata hemorrhagica. She will never pregnant, but she had an ovulatory cycle. So what am I saying? When you have a menorrhea, please see your gynecologist so he can guide you. So you don't come and tell people that you've had miscarriage 3 times, 6 times without any positive pregnancy test. Thank you.
Okay, thank you very much once again, Dr. Robinson. Our next question is, sir, thanks for your presentation. You did mention that losing 10% body weight greatly improves infertility outcome. Could you please give a bit insight on why this is so? Are there exceptional situations where weight loss is known?
I didn't get.
Okay, I will start from the beginning. You did mention that losing 10% body weight greatly improves infertility outcome. Could you please give a bit insight on why this is so? Are there exceptional situations where weight loss alone may not help?
Okay, thank you. Okay, I try to explain it. When the weight, when we talk about the weight, you know the fat, like I mentioned, the fat itself, fat metabolism increases the androgen value, you know, and we'll say the high androgen level is not good for fertility. So when I'm trying to make it very simple, when there is not much fat tissue, that androgen will be reduced. And once androgen, that thing, the metabolism that will lead to androgen production will reduce. And when it is reduced, the effect of this androgen on the production of female hormones that are responsible for fertility will now be reduced. And that female hormones will now be able to do its work in the ovary so the human can ovulate. That is a simple way I can explain it. Now, when you lose that weight, the fat, the contribution from the fat will be reduced, and then androgen will be reduced, and the other hormones, the ideal hormones we need the woman to get pregnant will be increased. Now, that does not mean that once you lose weight, anybody who lose weight will get pregnant. No. If you have lost weight and it is not forthcoming, we'll look at other issues. Okay, this one, weight loss alone may not solve the problem. She may need more help. That is induction, ovulation induction. That's what we'll now do ovulation induction. Many times we don't use ovulation induction as the first line, especially a woman who has got obesity, especially central obesity. I advise you to lose weight, unless your age. You know, when a woman is from 35 years and above and meet you, even if they are less than 8 months in marriage, you start investigating quickly to start treating them. But I think the woman who just 28 years just got married and meet you, you want her to at least stay for 1 year based on counseling before you start, because fertility management is very expensive. We want her to stay for 1 year before you start investigating all those stuff. If you want who is 35 years, who is almost approaching 40, you start. Even if she got married yesterday, you start immediately, even though books say start after 6 months. But for us, we start immediately because in our culture, most women will have lived with their parents for 6 months, 1 year, even before marriage. So we look at all those things. So that's why we don't follow what is written in the book holistically, especially in our environment. We domesticate it the way we see things and the way the culture is permissible by culture. Thank you.
Thank you, sir. So our next question is, are there specific diets to combat PMOS?
Okay, sorry, I didn't answer the second part of the question. You talked about supplements for PCA, for PMOS. Well, like I said, if it's affecting ovulation, there are a lot of supplements in town. There are a lot of supplements. And because I did not receive any adverts, I didn't receive any advert from any company for this presentation. I didn't receive any sponsorship. I don't want to mention any particular one, but there are some ones we've used that have given us results. We see use that giving us results. But I think your gynecologist is at the right position to prescribe for you the exact one that you need. We'll have like 1 or 2 supplements that are giving us a lot of results in clinic. In fact, there's a supplement we use that cannot fail us instead of using it. It's expensive, but it works for us, and we give it to our patient with confidence. But like I said, they've not paid me to advertise for them here, so I will not want to mention in it, but they are. Thank you.
Okay. Our next question here is, good morning, sir. Please, I'm trying to conceive, but I don't used to have discharge during my ovulation time, and my last scan show I have ovarian cyst. What is the best solution, sir?
Okay, so you can see it's like she is in the same category with Miss Anita. You know, she did a scan, had ovarian cyst. It's not just ovary. It's all about let's find out what is causing making you not to ovulate. So my advice to you that you see a gynecologist or probably a fertility specialist who will evaluate you holistically to know what you need. Like I said, it's not only ovary that is, it's not ovulation that is issue in fertility. We have the sperm, we have the fallopian tube, we have the uterus. So please see your gynecologist for proper evaluation. Then, and the earlier you do that, the better. Because what you see that when somebody is 27, 28, you keep on wasting time to 35 when the pollen becomes more complex for us to manage. So see your gynecologist. You may just need some few things to do, and then you will be pregnant. Yes, you just need ovulation induction, following the evaluation, and you get pregnant. Please just try and see your gynecologist. Thank you.
Okay, sir. Our next question is, my question is, what is your advice to a woman in her 20s, 30s who did family planning, which automatically stopped her from menstruating for almost a year now? Though she's done with childbirth, meaning she's not trying to conceive. Is that condition still healthy?
Yes, the family planning she did is it based on the one she did. Say the family planning stopped her messes. Well, it depends on what he did, but if the essence of family planning is that I don't want to get pregnant, and most family planning method we use is stops ovulation, and also go ahead to have some side effects. I'm suspecting possible she is using injectable, methodic progesterone injectable. We want to give every 3 months. Many times, sometimes can give you that kind of menorrhea. So if you don't want to conceive, your family planning has not elapsed. If it has elapsed, they may need to do another one. If it has not elapsed, you don't have any problem. Like I said, if you have completed your family size and they are not seeing your period, and I don't think you should bother yourself much. Just see your gynecologist, and once you roll out, there's no serious mobility or more within you, you are good to go. There's no issue at all. It saves you every monthly sanitary pad. So that is on a lighter note. So what I'm saying is that if you don't want to conceive, you may just go back and review, because I may not know the type of family planning you used. We have got a variety of them. So go and see the person that gave you the family planning, and then you can now you guys will look at it together and know whether you need to remove it or whatever you want to do with it. Thank you.
All right, thank you, sir. Our next question is, what is your advice for a 35-year-old, never pregnant, and has not seen a period for 4 years plus? Thank you.
So she's not saying a period for 4 years, she saw her last period 4 years ago. So it's a problem. She has got secondary menorrhea, and that's a serious thing. So she need to see the gynecologist. Let's find out what issues are. Because many times some of them may not see their period, but every month they'll have this kind of cyclical pain. So if you have this kind of cyclical pain, I don't know why that's the issue with you there. You used to have slow abdominal pain every month. That lasts for like 2, 3, 4 days every month. It means you are menstruating, but it's not coming out. What we call cryptomenorrhea. So then that one somebody need to open up something so that can come out, you start menstruating. If you're not having that kind of pain, then you need to do some evaluation to know whether it's like you're not operating at all. And then there is treatment for that. So in some way, you need to say gynecologist. It's not time to resort to self-medication. Let's know what is. So you are still very young, and your productive future is currently at stake. It's not well handled. Thank you.
Okay, thank you, sir. The next question is it normal for a 20-year-old not to have significant flow? She says she doesn't need to use pads, and her period is usually 2 days. Is she all right?
Okay, it depends on when her period started. You know, has it always been like that since she saw her first period? That's the question. Has it always been like that? If it had always been like that, if it had always been like that, then she will need some evaluation. But if she was having, we need to compare. You know, if you have been having normal flow in quotes, and suddenly it start dwindling, then she needs to evaluate it. Let's be sure. Let's look at the ovulation again. Let's look at the inside of the womb again. Because if she has got what we call a uterus signing, or Asherman syndrome, as case may be, if she has got it, it means that the endometrial line inside of her womb has got some issues, that is making it difficult for the womb for blood to come. I don't know how to say it, making it difficult to have enough menstruation because of the scanners, and there's a scan inside her womb, or call it transgenic. You need to come, you need to look at it, and if that's the case, it's a very small procedure in theater. Do the visualizes, the catheter there, then give her some hormones to regenerate and renew the endometrial lining, and her period will come back again. So I think she needs evaluation. We need to know why. So it may just be PID, pelvic inflammatory disease that she has got, that now we well treated. By the time we check it and the pelvic inflammatory disease, we treat, and she just be fine. And let me also say it here that the most young ladies do what called douching using chemical medicated soap to wash your private parts. Some advocated. But the nature made that there's a bacteria called lactobacillus that is normally, situated inside your private part, inside your vagina. And what does it do? It tries as much as it can to fight against microorganism infestation, infectivity inside your vagina. So by the time you use, and that is it's acidic, lactobacillus it works in acidic environment. So by the time you use this your medicated soap to wash your private parts, you keep those lactobacillus. Then any little infection, bacteria that come in will just infect you. And once it infects you, it may now ascend into your genital tract, genital tract, and cause what called pelvic inflammatory disease, endometriosis. And when we have that, it can also affect your meses, it can block your tubes. So these are practices that we must, as much as we can, try to avoid. Thank you.
Okay, thank you very much. The additional comments on this question you just finished answering is, it has always been like that the menstruation has always been like that. She didn't start menstruation early. She started around maybe around 15 years old.
Okay, it has always been like that. So please, you need some you need the evaluation. Let's look at inside of your womb. Let's look at your ovary. Let's take blood sample from you to do some investigation.
Okay, so the next question is, if we come to e-clinic, can you recommend the supplement or via online consultation with you for those not around or in Aba?
Okay, the supplements. In e-clinic Aba, we do that what you call e-clinic. So we have our ICT guys that we contact, and they will tell you how to reach us, and we'll discuss further. But once you come to e-clinic Aba, we're definitely going to get the supplements. Even by online, you can consult us. We are on TikTok, we're on Facebook, and people manage it, and they have a way of getting across to us. So there's no problem about that.
Okay. Ms. Oluwayemisi Ajoke, do you still want to talk? If you want to, please unmute yourself. Okay, I want to believe our question has been answered. Do you have anyone? Is there any other question you'd like to ask?
Yeah, there's a question you're
the last
missing out
question
in
we
the...
have here, sir?
There's a question you're missing out in the chat box.
I saw it. I'm just asking so people can also drop question before we treat the last one. Can PMOS reoccur later in life after treatment? Is it permanently cured?
Say whether I can.
Reoccur later in life after treatment. Is it permanently cured?
Okay. No, you see, okay, let me answer it straight. It can occur. See, it can also, it will not occur. Okay, let me explain. Because I'm discussing fertility, if a woman had PCOS and get pregnant, following delivery, if she was properly taken care of during the pregnancy and she abide by the instruction of the gynecologist in terms of weight, in terms of eating habits, nutrition, eating healthy, it's very unlikely that she may need help again following delivery, and that can be regarded as a permanent cure. However, what we see that many times when they get pregnant, they will forget after delivery, they will forget all those practices, all those instructions they were given. And that's why they will need another set of ovulation induction for them to get pregnant again. And that is not permanent. Now, if the POS has caused diabetes mellitus, because if I know that was the PMOS has caused diabetes mellitus, then of course you can't say permanent. Diabetes till you keep on with the drugs, keep on taking the drugs. So there's not permanent. So it depends on what the PCOS has caused. Just that. It depends on what it has caused. So if you just ovulation induction and the woman will resort to is very critical about, is very careful and intentional about her eating habits, then you just go ahead and it can be done as a permanent cure. I don't know if I've answered the question.
Miss Bernardine, if you want to ask any other question as regards to his response, you can speak now. Okay. Sorry, she asked additional questions. Say, sorry, I'm not clear with your answer, sir. Can you please recommend healthy food and diet we can take to avoid or reduce chances of PMOS? Also, kindly highlight food that should be avoided to reduce the risk of getting PMOS.
Okay, thank you. First of all, the component, the PMOS, PMOS. Okay, let's say the component could be ovulation is just part of it, the infertility. Now, if we've investigated, this person has not got diabetes mellitus. This person has not got cardiovascular disease. Well, let me judge that the problem was just infertility. Then you do a ovulation induction and the woman gets pregnant. And she continued eating healthy. What I mean healthy? I mean healthy, nutritious eating, feeding is balanced diet, as we are taught even in primary school, and avoiding too much carbohydrates at night. If possible, avoid eating carbohydrates after 7 p.m. Then avoid junk foods. I don't want to start mentioning the junk food. You know what junk food is? And eat well. Avoid them as much as you can. Then do more of proteins, and then do more of fruits and vegetables. These are healthy feeding. If you do that, it's very unlikely that you are going to be induced again your next pregnancy. The ovulation is said to be corrected, and one cannot say the PMOS is permanently cured. It's permanently cured. Even when you have got type 2 diabetes, many times when you do your exercise and reduce your weight, you may not even need drugs for that, but you'll be consistent in whatever you are doing in terms of the feeding, healthy lifestyle, your exercise. So you may not need medication for the type 2 diabetes. You just need on diet. And one can say that is permanently cured relatively. But when you resort to your old way of doing things, it's very likely that you will recur. And like I said, the treatment is individualized. How we manage Miss Joy is not how we're going to manage Miss Anita. It's not how we are going to manage Mrs. Yinka, because their position differs. Like somebody mentioned about hirsutism, that is a certain way growth. If that's just the only problem the person got, then it means that her problem is to control it. If the person presents like Mrs. Anita, and Mr. Anita that of diabetes, you handle the diabetes. So you cannot say, let me cure it PCS once and for all. We cure it based on the presentation and the desire of the client. Thank you.
All right.
Thank you, Bernardine. Thank you.
All right. Our next question is: my woman was pregnant, and at 3 months, she started having severe pain. On getting to the doctor, she discovered she had fibroid that eventually led to evacuation. Should we remove the fibroid and try again? Or what do you advise?
No, so she started having severe pain. Can I come again?
Yes.
Pain, okay, pain.
Yes.
Pain, not bleeding.
No. Started having severe pain. On getting to doctor, she discovered she had fibroid that eventually led to the evacuation.
Eventually did evacuation.
Yes.
Wait, so sorry. Which means she was bleeding.
She was pregnant. My woman was pregnant, and at 3 months, she started having severe pain. On getting to the doctor, she discovered she had fibroid that eventually led to evacuation.
Okay.
So the poster did not include whether she was bleeding. It's okay. The poster said yes. That means she was bleeding.
She was bleeding. Yeah. So because no doctor will want to do evacuation because the woman has fibroid. Okay. Yes. 3 months. Oh, sorry about that. I sympathize with you. But a woman who has fibroid can be pregnant. It depends on the location of the fibroid. Very important to mention. Fibroid can be located outside on the outside wall of the womb, what we call serosa. It can be located inside the muscle, what we call intramural. Can also be located inside the womb itself, submucous. So the one that may cause miscarriage is the one inside the womb. So it depends on where the fibroid is. So if the fibroid is in the muscle of the womb, so it may not cause miscarriage, but it may be causing pain. In fact, as a matter of fact, there was a lady that had fibroid of 40 weeks size, 40 weeks, as in, if you see her, you thought she was 9 months pregnant at the clinic. And when she took in, the sonographer scan, I said, Chief, come on, there's a baby inside this womb. How do you think we should remove it? The fibroid is too much. And I asked her, are you the one that put the baby there? Baby is already there. And you know one thing, that woman was delivered of that baby vaginally for 2 weeks. So that it was after the delivery, 6 months more after delivery, that we now did a fibroid operation and remove the fibroid. What am I saying? So fibroid can cause the pregnancy. The only thing that the patient should know that should be admitted severally. She may be admitted severally because of called degenerative changes in pregnancy of the fibroid. So the fibroid may give her pain, but when she comes, we admit, we give infusion, give analgesia, we cancel her. She will go back after 2 days. She may come back in the next 3 months till she put to bed. That one may not cause miscarriage. But the one that will like to cause miscarriage is the one inside the womb, because the baby, you'll be competing with the baby inside the womb. That's why the baby is inside the womb. That one can cause miscarriage. And we'll advise that before you think of next pregnancy, sir, do a scan. Let's find out where the fibroid is. If that fibroid is inside the womb, it should be removed. Thank you.
Thank you very much, Dr. Robinson, for the presentation today. And to all people that attend our special, really appreciate your attendance. And I will be calling on Dr. Nadia Sinachuku now to give us his final remarks as we are wrapping up this session. Dr. Nadia, over to you, sir.
All right, thank you, Ms. Obadara, for the coordination. Thank you, Dr. Ugwuanyi, for the erudite presentation. Thank you for the insightful presentation too. Thank you, our dear listeners and our dear online viewers, for making our time. Wow, it's about 2 hours and it's been engaging. Everybody has been on this and trying to learn one or two. Actually, topic was supposed to be from PCOS to PMOS. But when we discovered that many people might not understand what PCOS is, we say, okay, let us talk about PMS and what PMOS can cause. I know living here, we must have taken one or two things from you. There are clinicians in the house. See a lot of clinicians here. You're able to make your practice more robust in managing clients. And as Dr. Ugwuanyi has said, for listeners that like to self-medicate, everything is not about self-medication. What works for A might not work for B, because care is actually individualized. At the Clinic and Diagnostic Limited, Abuja and Aba, we have specialists that see to your everyday needs. If you want a gynecologist, you can get a gynecologist and it will be booked for you. You can even seek their services online. So what we try to do is to make people know about the current trends of the health and what practices they are needed now. See, ignorance has led to many people dampening their own health. But once you know some things and maybe that doctor in the house is telling you something, when I mean the doctor in the house, the doctor that didn't have the qualification is trying to tell you, I took this drug, so please take the same drug. It worked for me, so it can work for you. I think at this point you could say, no, I need to see a gynecologist that would help to sort out my needs. Apart from gynecology, you just have to get to the hospital to see the doctor. So once again, I wish you a pleasant weekend and I invite you. This presentation holds monthly. So just check out for our Facebook, TikTok, Instagram, adverts, and you always find us online. God bless us, and thank you once again.
Thank you very much.
All right. Thank you, everyone. Until our next webinar. See you again. Bye. Enjoy the rest of the weekend.
Thank you.